Now, every instrument has three parts. This is called as jaw, this is called as shaft, this is called as handle, and it is made up of three components. One is called as handle, another is insert, and another is sheath. Once it is assembled, then this is jaw, this is shaft, and this is handle. But once you will disassemble, how to disassemble, all of you will learn how to disassemble, but first I am demonstrating you. You have to open this cap, then open the handle and it will come out, and then open the insert, this insert. So, this is insert, this is sheath, and this is handle. The shaft is consists of insert and sheath. Now, insert is only the difference in the instrument. Insert of seizures, insert of grasper, insert of Maryland is only difference. Handle and the sheath is same for every instrument. Like suppose if the sheath is broken, you do not have to buy, you can just get the another sheath, and if the insert is broken, you can buy only insert. Every instrument company of the world, they now make the instrument in a same way. Although one company instrument will not fit to the another, but all of them they make it, all the reusable instruments are made of three parts. Now, how to assemble? There is a ball here. So, you will put the insert into the sheath and then screw it, and after that open the handle. Once you will open the handle, a socket will come out. There is a socket and this ball will go into the socket, and once ball will attach with the socket, then you close it and then you put the cap, and that is all. Do you know why you need to remember it? Because sometimes suppose you are using any instrument and suppose this insulation is failed. Now, I am in trouble. If this insulation is failure, this will be dangerous because it can burn. But suppose I have to use this instrument anyway, then I will take the sheath of this one and I will attach to the insert of that one, so that my surgery will not interrupted, it will continue. So, that is why changing of the sheath and insert you have to learn. During surgery any time you may need to, and another important thing is you have to train your nurse. After each surgery the instrument should be disassembled after each surgery, and once you will disassemble it, then only it should be cleaned. It should never be cleaned in the assembled state. If we are cleaning it from outside, it is useless, it does not work. So, it has to be disassembled and then. So, just one time if you will learn, it will happen. I will tell you how to do. You have to hold the handle and hold this rotating knob, and then you open the cap, and once the cap is open, then open the handle and it will be disassembled, and then open the sheath. So, it is very easy, but one thing is important, if handle is closed, then socket will not come out, and if the jaws are open, then this ball will also disappear. So, jaws should be closed and handle should be open at the time of assembling and disassembling, and then it will work, and then you can attach it like that. Sometime by mistake, if it is not attached properly and suppose you have put the cap like that, then your instrument does not work, and here we can see it does not work. You think that it is defective instrument, but it is not defective. The problem is we have not assembled it properly. So, immediately you can open it and you can see that how to assemble properly. So, what to do? Introduce the ball into the socket. Starch has made one new generation of the instrument, that is called as click line. In the click line you have to push the ball into the socket, but most of the other company, just like our soldier joint, you have to attach the ball into the socket, and now it is done. So, it is very simple, anybody can do. Now, once you will start the laparoscopy, then first instrument which you will introduce into the abdomen is atraumatic grasper. This atraumatic grasper, the definition is, it is fenestrated low serration double action jaw grasper. Fenestrated means it has a hole here, and low serration means serration, if you will see the serration on the jaw is less than 0.1 millimeter, and double action means both the jaws are working. This is double action. There are two group of instrument in laparoscopy. One is single action jaw, another is double action jaw. Whenever you have to use hard work, you should ask for single action jaw instrument. Like suppose you want to hold the myoma or you want to do myomectomy, enucleation of the myoma, you should never use double action jaw for those purposes. If you will use it, what will happen? Immediately your instrument will break and you will be in trouble, because double action jaws are very weak and they cannot sustain the large force. That is why needle holders, claw forceps, stone holding forceps, these all are single action jaw. That is why these are strong, and the graspers, Marylands, these are the double action jaw. So, this is atraumatic grasper. If I will hold it like that and if I will tell her to hold it and just press, she is pressing, open the jaw and press my finger, press as much as you can, press it, press more, see I am not crying, and open it, see this is my finger is little bit impression is there, but if I will do like that, this impression is now gone. So, that is called as elastic deformation. Atraumatic grasper only creates elastic deformation. So, advantage is, suppose you are holding the tube also, tube will not be damaged, but if you will use other graspers, tube may get stricture, or if you will hold the appendix, appendix may get appendicitis. So, that is why always start with the atraumatic grasper. Now, suppose you have decided that I have to continue the surgery, and then in those situations your tissue is little fibrous, like there is a edematous gallbladder or endometrioma, or there is a tubo-ovarian mass with the dermoid cyst. In those situations, atraumatic grasper is useless, because you will try to catch it and it slips, it does not work. So, you have to take a semi-traumatic, this is semi-traumatic. In this also it is a double action jaw, but serrations are very deep serrations. The serrations, if you will see this is serration, can you see? It is very deep and sometimes it is more than 0.1 millimeter. So, in those situations, if I will tell her to press my finger, then I will start crying, because it will create plastic deformation. Plastic deformation means irreversible deformation. Third group of grasper is called as traumatic grasper. Traumatic graspers are just replica of our Ellis forceps. These are the traumatic grasper. It has 3 tooth in the lower jaw, 2 tooth on the upper jaw. It should never be used to hold the tube or the bowel. If you will use it, you will be a big problem, because it will perforate. So, accidentally you should not use traumatic grasper. Whenever you are using grasper, you should must inspect the jaw, that I am using the correct grasper for correct work. Traumatic grasper we are using sometimes, suppose there is a lot of edematous fibrous gallbladder, then we are using to hold it, but we are always ready for perforation and it perforates, but we suck or we can just do irrigation suction to clean it. So, this is, and you know most of the traumatic graspers are, not all, but most of the traumatic graspers are single action jaw. Single action jaw means you can see here only one jaw is moving, another jaw is fixed. So, single action jaw instruments are very strong, because they have only one joint here. Double action jaw instruments are weak, because they have 3 joints, one in the middle and 2 on the either side. So, these are the single and double action jaw, which you have to keep in mind. Now, third instrument which I am going to demonstrate to you is the Maryland. So, basically you know there are sometime during surgery you will listen from your consultant that it is a fundus grasper, it is a Huntsman pouch grasper, it is a dolphin grasper, it is a peacock grasper, but do not get confused by those names, because those names are trade name given by the company. So, and the same fundus grasper which is used by surgeon to hold the fundus of the gallbladder, gynecologist can use it to hold the ovary. So, we should not give a name to the any grasper. Graspers are generally you should scientifically described as atraumatic, semi-traumatic and traumatic. Now, come the Maryland. Maryland is bowel grasper is also atraumatic grasper, but only difference in the bowel grasper is the bigger the jaw of the grasper will be, less traumatic it will be there. It will have less trauma, means very less trauma. So, shorter the jaw is, it will be more traumatic, because it is a lever action which works. So, if the jaws are long, then it is atraumatic. So, bowel graspers are basically atraumatic grasper with little long jaw, that I am showing you, he is bringing, I will show you. Now, this is Maryland. Maryland is basically a dissector. It was Maryland was given the name Maryland on the University of Maryland, that is one of the state university in the USA. So, this Maryland has three functions. One is stripping. Suppose you want strip the peritoneum, then only Maryland can do. This is a stripping function, like you want to strip the peritoneum of the gallbladder, or you want to strip the anterior leaf of the broad ligament, or you want to strip the visceral peritoneum during the splenectomy or nephrectomy, then you will use the Maryland only. Another function of Maryland is opening the window. Many times we have to make a window in between the artery and duct. In those situations only Maryland can be used, just like it is a replica of our artery forceps in the open surgery. When you have to make a window in the cystic duct and cystic artery, you cannot use graspers, you have to use the Maryland. You must take care that opening of the jaw of the Maryland should be in the line of the vessels. It should not be at right angle, otherwise it will puncture. So, always keep, because we do not have depth perception in laparoscopy and we do not have tactile sensation also. So, always try to keep it parallel to the vessel. Even splenic artery, splenic vein, renal artery, renal vein, you have to make a window before clipping. At that time Maryland will do. Another third work of the Maryland is hemostasis. Whenever you have the hemostasis required, only this instrument can help you. Like suppose you are doing hysterectomy and unfortunately uterine artery got started bleeding, then you cannot hold it by grasper. If you will hold it by grasper, it is risky. Do you know why? Because you will hold a bunch of tissue, and if you are holding a bunch of tissue, there may be possibility of remote injury, because more tissue you will catch, then remote injury will happen. What is remote injury? I will discuss during the electrosurgical dissection techniques. And Maryland tip is thinner and pointed. So, if you will hold it by that, remote injury will not occur. Maryland is of two types, one is monopolar, another is bipolar. So, I am showing you bipolar Maryland. This is bipolar Maryland. It is also called as Roby dissector, because Roby has invented it, and it has two poles here, and this is very, and I think must have instrument for the gynecologist for the hysterectomy, that is Roby dissector. Even if you have a ligashore or harmonic, this bipolar Maryland is required, because sometimes suppose ligashore could not coagulate it and the harmonic is failed, then only the bipolar Maryland helps you. Monopolar must be avoided in gynae practice, because you can burn the ureter, but bipolar is safe because current only travels in between the jaw. It has a plastic joint here, so that is why it is not getting short circuited. So, how you can differentiate between the monopolar and bipolar Maryland? That in monopolar Maryland it is a metal joint here, and in bipolar you will see there is a plastic joint here. In monopolar you will see only one pole is attached here. In bipolar on the back you will see the two poles are there, positive, negative, both is going together. Whereas in monopolar only the active electrode is attached here and current is returning by the patient return plate. So, current is travelling through the body of the patient, and that is the reason sometimes other organs also can be injured. You are performing surgery in the uterus and maybe bowel is burning somewhere or ureter is getting a stricture in the monopolar, but bipolar is absolutely safe. So, this is bipolar Maryland. Sometimes you have this right angle Maryland also. This right angle Maryland is very useful sometimes if you are doing nephrectomy or other procedure. At that time you can use a bipolar Maryland. Just I will like to show you, suppose you are doing nephrectomy and here this is the nephrectomy video. In nephrectomy there is one problem. Problem is that your renal artery and renal vessels are very much parallel to the abdominal wall, lateral abdominal wall. In those situations what you can do, you have to make a window in, this is vein, this is renal vein and below is vena cava. Now, the curved Maryland will not do. In those situations you can put one more port and you can use a right angle Maryland to make a window. So, we will see here, this is just the renal vein and this is vena cava, this is little fat which is separated to just facilitate the entry of the Maryland. And now, this is suction irrigation. Suction irrigation is doing little blunt dissection. This is right angle Maryland. Can you see that? Here, see the tip. So, its tip is completely right angle. This is the Maryland and this is tip, and now you can open the jaw of the tip and the jaw of the tip. Can you see that? This is very useful for those complicated cases where tip of the Maryland is required to see, and then just like open surgery, there is no difference. Sometime open surgery also you are using right angle, so that you can see the tip better. So, this is like nephrectomy and it is done with this procedure. Exactly same way, sometime in cases of hysterectomy and other procedure also, I will show you later in which it is used. Now, the next instrument which we will discuss is this is Babcock, or it is used for holding the tube. Sometime if you want to do tubal recanalization, so it is like a Babcock, so that tube will not be damaged. So, it has a little groove there, can you see that, and there is a opening, so that it will just hold the major salpinx, it will give less pressure over the tube. So, this is also one of the instruments. You can just pass it all those instruments one by one to all of you, so that they can differentiate and it can make a circle. Now, the next instrument which I am going to demonstrate to you is scissors. In laparoscopy, generally there are 4 type of scissors are used. Why 4 type is required? Because according to the need, you have to ask for different type of scissors. First, we should learn how scissors work. You know, scissor works in 4 stages. One is called as engagement, another is called as elastic deformation, third is called as plastic deformation, fourth is called as fracture and dislocation. All the scissors work on these 4 stages. Like suppose I have to cut it here, and suppose I will take this scissor, I will give her this scissor, or I will give him this scissor, and suppose I have a tube block, and if I have to cut any structure or any suture or even this, and if I will tell him to cut, he will not be able to cut, because he is not able to engage. If he will cut, it will not work, because as soon as he try to cut, it is getting disengaged. So, in open surgery, how it will be engaged, that your assistant will push it, then it will be engaged, but in laparoscopy there is no one to push it, because to prevent engagement you have to have the big jaw scissors, because if you not want the tissue to get engaged, then the contact angle between the tissue and the jaw of the scissor should be only 15° maximum. If it is more than 15°, instead of cutting, it will start pushing. So, just like now this jaw, if I will give him this scissor and I will tell him to cut, he will not have the problem, he can cut it, because now there is no problem of engagement, because if you see very carefully, jaws are too big, and that is why contact angle is less, and contact angle is less, it will not push, it will cut. That is why garden scissors are very long jaw scissors, so that gardener can cut the stem of the tree also with the garden scissor. But if you will give the gardener to cut the tree with a mustache cutting scissors, he cannot do any work, because contact angle will be more than 90°, and he want to push the scissor, it will start pushing it back. So, there is no engagement, but laparoscopy has a problem that you cannot make a long jaw scissors, because instruments are small in diameter. So, to prevent the engagement, there is one hook scissors. Hook scissors are beautiful scissors which does not have problem of engagement. Like this scissor I am giving him, and then I will tell him to cut, and now he do not have a problem, he is holding it like that and it will cut. Press more tight, yes, it is cut. So, I will show you, sorry, this scissors, if you are holding it like that, see, it is cutting so nicely, and it is cutting without problem of disengagement, and it can cut in so many pieces, it is cutting. So, do you know, and this is the only scissor which cut distal to proximal, all the other scissors are cutting proximal to distal, but this scissors is beautiful scissors in laparoscopy, which can be used to trim the mesh if you are using sacrocolpopexy, or if you have to cut the very strong ligament or tendon, or if you have to cut the suture even. Sometime if you have a PDS, proline, and you want to cut, you should ask for hook scissor. Another advantage is wherever want you do the control cutting, you can use it. Like suppose you want to do tubal recanalization, and suppose this is the tube, and in between there is a Fallop ring here. This is a Fallop ring. I have to cut this side, I have to cut that side also. There is no problem. I will go, I will cut this side and I will cut that side, and it is done. So, the advantage is that I have a sharp margins, and then I can do the recanalization. If I will use these scissors, there will be hesitation cut, and major salpings also will be damaged, because in other scissors it is cutting proximal to distal, but hook scissor is cutting distal to proximal. So, one of the advantages is cholangiogram. Suppose you have to do the cystic duct cholangiogram and you want to cut the cystic duct partially, so that you can introduce the ureteric catheter, then you will use these scissors. Like suppose you open the jaw and you will engage it partially half and cut it. See, she has cut beautifully only half, and then I can introduce without cutting, I can introduce a cholangiogram forceps and ureteric catheter, I can inject the dye. But any other scissors if you will use, it will be not possible, or it will give you lacerated margins, because there will be hesitation cut, and if there is hesitation cut 2, 3, 4 attempt you are cutting, then the serosa or the cystic valve will prolapse, and after that your catheter will not go. So, hook scissors are very useful for those purposes. Now, there is micro scissors. These are micro scissors. Micro scissors are used wherever there is a flimsy adhesion. Like suppose you want to do fimbrioplasty, there is a tube and there is a distal tubal obstruction, and you want to open or you want to do neosalpingostomy or fimbrioplasty, then you have to ask for micro scissors, because these scissors are too big for those structure, and moreover if the micro scissors are there, there is a less chances of reblockage, less chances of blockage. Do you know why? Because micro scissors has the advantage that the cut surface area is very thin, and then chances of fibroblast and collagen to grow again is not that much. Do you know there are two structures in the laparoscopy where we are not allowed to do the blunt dissection. One is direct adhesion of the bowel, other is tubal adhesion. Suppose directly serosa of the bowel is adhered with the anterior abdominal wall, then you should not try to do the bluntly dissected, otherwise always the serosa is weaker than the scar tissue and it will tear, it will. So, in those situations you have to do sharp dissection, so that you can separate it better. And another advantage of using the sharp dissection is that suppose if it is perforated also, suturing again is easy. If you will tear or lacerate, suturing will be difficult. So, that is why bowel or tube you should use the micro scissors wherever flimsy adhesions are there. Now, another one is curved scissor. This is the curved scissor. Curved scissor is the curved scissor like that, this is also curved scissor. So, curved scissor has advantage, the tip is more easily visible. So, whenever you have made a window in between the cystic duct or cystic artery or renal duct renal artery, and you have clipped, and then you want to use, then use curved scissor. So, that just by rotating the jaw you can see the tip of both the jaw, because tip is curved. That is why even in the open surgery we use curved scissor, so that we can see the tip better. Curve, C-U-R-V-E-D, curved scissor. So, that is how the curved scissor, same way this is the curved scissor in, it is curved, can you see that? It is little curved. So, curved scissor in laparoscopy is used. So, these are the four, and another is a straight scissor. This is a straight, just like the straight scissor which we are using. Suppose you have to open the serous layer of myoma to do the myomectomy. In those situations you can use the straight scissors. If you use curved scissor, there will be curve margins. Or if you want to explore the CVD for choledocholithotomy, or if you want to do pyeloplasty, in those situations you can use straight scissors also. So, you have a straight scissors, you have curved scissors, you have micro scissors, and you have hook scissors. So, these are the four type of scissors. Depending upon your need, you will use any of these scissors. Now, the next instrument which I am going to demonstrate to you is the clip applicator. There are two metals which is used in laparoscopy frequently. One is titanium, other is nitinol. Titanium and nitinol, these two metals are used worldwide for the surgery. The nitinol, N-I-T-I-N-O-L, nitinol is used by cardiac surgeons also for the cardiac bypass to join the vessels. Nitinol is also present in the Assure 2 which is used for the hysteroscopic implant. In that Dacron and nitinol is the component. Nitinol is also used for the staplers, and it is expensive. So, cheaper alternative is titanium, and these are the titanium clips. Titanium clips are available in three sizes, that is blue, green and yellow. Blue is used generally for the up to 3 millimeter of the vessel. If you have a very small vessel, you can use blue. The green is used up to 6 millimeter of the vessel, and yellow is used up to 8 millimeter of the vessels. Like if you have to do renal artery, splenic artery, then you will use yellow, or if it is a dilated cystic duct, then you will use yellow, or if you want infundopelvic or ovarian artery with a not escultinized with the entire bundle, you can use yellow. And green is up to 6 millimeter. Green is called as medium large, yellow is called as large, and the blue is called as a small size. Blue is up to 3 millimeter of the vessel, but blue is very less used, rarely used. Do you know why? Because up to 3 millimeter of the vessel we can cook by the electrosurgery. So, you do not need to use it, but sometime if you do not want to cook it, then in those situations you can use the blue color. And green is maximally used, because most of the vessels which we deal with like cystic artery, uterine artery, ovarian artery, those all are mostly the green color. And yellow is also used less where there is a dilated cystic duct. In those situations you can use yellow, or renal artery, splenic artery, you can use yellow. Pardon? Pardon? Green up to 6 millimeter.
You need a different clip applier for the yellow one?
Pardon?
Do you need a different clip applicator?
No, you do not have to use different clip applicator, you can change the jaw. You can change the jaw, you will open it and you can bring the another. So, these are the bigger jaws. So, this is opening out and then you can attach the another one like this, and then you can tighten. This is for large one.
All manufacturers do that?
No, Starch is not doing that. Starch, what they are doing, Starch is changing the insert. Do you know why? I will tell you, there is a reason behind that. Indian company, they only make, or many companies they only make the tip, but tip has one problem, that suppose accidentally your nurse has forgotten to tighten it and you drop it inside, and if you are applying the clip applicator, it is possible that it will drop it in, and now you are in big trouble. Suppose you drop it in and lost in between the coil of intestine, then what will happen? So, always if you are using this, you must check it outside that it should be nicely tightened. Another problem is that suppose if it is not nicely tightened, if it is little loose, then once your nurse will give, and suppose nurse does not like you, then what she will do? She will make it little light. Now, what will happen? See, you are tightening it more, but still the gap is there. Can you see that? And this gap means your clip is loose. And do you know why? Because it is not fully tightened. So, you have to make it sure that it is fully tightened. So, to prevent these complications, Starch is making entire insert, they are making it long. So, if the insert is up to here, it cannot be dropped anywhere, and another, it has also ball and socket. So, there is no possibility that it will be loose. So, that is why those companies are making, but to prevent, to minimize the cost, other companies they are making only the tip. Now, when you have to apply the clip, you should hold it by the shaft, you should not hold it by the handle, and hold the shaft, keep the cartridge perpendicular, and then you will press it. You press, and as soon as you press, it is loaded. Now, the clip is loaded. Can you see that? It is loaded, and now you will hold it, and then you will introduce it in, hold the handle, introduce it in, and then little bit rotate, so that you will be able to see both the tip, and then you have to press it. And after pressing, keep it pressed for 3 to 5 seconds, so that there will be elastic and plastic deformation. Plastic means irreversible, and after that open the jaw, and then do not pull directly, go little up or down. See, if sometime if you will directly pull, it get back. Yes. So, this is important. That is why I did like that. So, directly you should not pull it, because sometime it get engaged by the jaw, and that may be dangerous. So, that is why during the engagement you have to bring it little up or down. So, now I am again press it, very good, open the jaw, excellent, and then you go little up or down. Up means like that or down, and then pull. Now, it cannot be detached. Directly after pressing, directly you should not pull. Little up, little down means you try to little disengage and then bring it out. Yes, most of the time, even if you will pull directly, it will not pull the clip back, but it may be possible it make the clip loose, and then after 1 or 2 days, this clip can slip and the bile will keep on leaking and patient will get peritonitis. So, that is how important. And then there should be a dumbbell formation. Dumbbell means constriction in between and swelling either side, and if a good dumbbell means there is a good hold over the tube, dumbbell means constriction in between, swelling either side. Now, you have to apply 3 clip and the distance between first and second clip should be 3 millimeter and the distance between second and third clip should be 6 millimeter, and then you to cut in between the second and third, because if you will cut too near, one clip will nullify the dumbbell of the another and both will be loose. Both will be loose. Sometimes what happens, you do not have a big stump of cystic duct, you have a very small cystic duct and you have applied one clip and then you are applying another over the same. Just I will show you, I am giving the second clip, hold it and she is applying one over another. Now, press it and leave it. Now, you will see both is loose and both is out. Why it happened? Many a time the reason is that we have the, this is plastic, that is why holding, otherwise it will come out. Reason is the dumbbell of one will be nullified by the dumbbell of another. Just like simple, when you are tying a knot also, suppose you are doing hysterectomy, taking a bite and you are transfixing, here you are not transfixing, you are just pressing it, and suppose you have a very small stump, there is a possibility that your knot will slip, or if you tie another stump, another knot in front of the very small stump, it will make the first knot also loose. So, that is why you should not tie too nearer and you should not tie far away also, otherwise there will be necrose area in between and then the second clip will be dropped, and sometime this second dropped clip can migrate into some of the unreasonable desired area. Like there was one case history that one surgeon was performing hernia surgery and some spermatic vessel branches started bleeding. He applied 2, 3, 4 clips. Those were not the real vessels, these were just the tributaries of the vein. He applied 2, 3, 4 clips and then put the mesh and then closed the peritoneum. After a few weeks, all those clips has migrated into the sac of the hernia and it was palpating into the scrotum. So, then he has to do the surgery to remove it. Another case story, that 12-year-old girl, she was gymnast and she underwent for the cholecystectomy. 1 year later, she has severe backache, and when the surgery, when the MRI was done, then it was found that the clip has migrated the retroperitoneum and was pressing one of the nerve. Reason being that during her job, she has to bend the abdomen and entire vertebra, just like a doll you are seeing in the gymnast how they do. So, those type of activity and a lot of pressure on the muscle and abdominal wall has pushed those lost clip into the retroperitoneum and it was pressing the nerve. So, unnecessarily why we will do this risk. So, that is why, although it is very less, it is very less. Another problem of the clip is cat eye stone. What is cat eye stone? That sometimes suppose you have a very large dilated cystic duct and you do not know how to do the knot. Now, what you are doing, those clips are not possible to apply. Then we do a step ladder fashion. A step ladder means apply one clip and then cut it, apply another and then cut and apply third. So, actually you are applying this one, another, 3 clips subsequently, or some people they apply one from this side, another from that side, and so that they do not have large clip or they do not know the knotting. Now, in those situations, those clips are not projecting beyond the structure. If the clip is projecting beyond the structure, they are safe, but if clip is not projecting beyond, suppose it is excusing into the structure, then with the phagocytosis it will get internalized into the lumen of the cystic duct in due course of the time. And once it will get internalized, because why? Because you have pressed it over the tissue, it is not projecting this way. If it is projecting, it is safe, but if it is not projecting, it is like that, then it will get internalized into the lumen. And then Professor Bursey has found that he has performed one surgery of cholecystectomy. 1 year later, patient came with the jaundice. He did open choledocolithotomy and took the stone out, and in curiosity he cut it. Inside he saw the pupil of the eye of the cat. If you will see the pupil of a eye or tiger in the cat, or eye of the tiger or cat in the dark, have you seen that yellow like slit? Exactly same way titanium clip was looking inside this stone like a cat eye. So, that is why he has coined the name cat eye stone, and cat eye stone is one of the long term complication of using the titanium clip in the cholecystectomy. It is very rare complication, but it happens. That is, some of the book is writing cystic duct clip stone and majority of the book is writing cat eye stone. that is the typical name, because it looks like a eye of a cat. So, that is why to avoid these problems, you should try to use the appropriate size of the clip, and clip must be projected beyond the structure. Another method of minimizing the cat eye stone is you should use the knot. If you use the knot, there will be no any problem. Third is you can use hemolock. Hemolock is one of the substitute, that is a silicone clip, and these hemolocks are beautiful, and it can be used with the separate applicator. This is the applicator for hemolock. It is little expensive. The cost of the titanium clip is 600 rupees, 500 rupees for 6, but hemolock is little expensive, that is approximately it comes up to 2500 also, and you will press it like that, and you press it and then take it out, and here it is out. This is hemolock. Then you can just pass it to everyone. It is just like how our hair clip works. When we press the hair clip, it will, there is a socket, there is a notch, and it gets joined. Or just like in the computer or in the TV, they are encircling the bundles of the wire with the one plastic lock. It is just like that. You see, that is why it is called as hemolock. And it does not have any problem with the MRI also. The post operative MRI can be done directly, and it does not have a problem of any cat eye stone also, because it is inert material, it does not get migrated, and it does not cut the wall also. But there is one problem. Problem is that it should be of adequate size. Here you can do a step ladder, but hemolock cannot be applied as step ladder, because until it goes to the opposite side, it will get not locked. If suppose this size is just for cystic duct, if you are applying it for renal artery, it will not work. For renal artery, you have to use large size, that is yellow color, and then it will work. So, this is the problem with the hemolock, that this titanium anyhow I can apply, because titanium is only pressing, but it is locking, and locking is only possible if it is entirely encircling the structure which you want to lock, otherwise it cannot lock. So, these are the alternative for the clip. Now, next instrument which we will discuss is the different type of needle holders. These needle holders are.
So, these clips, do we use them in gynec surgery?
Yes, we use in gynae also. Do you know, actually some people are using for tubal sterilization also, but ideally titanium should not be used for tubal sterilization. You should use either Hulka clip, Filsey clip or Fallop ring, because it is metal, and sometime it may get internalized into the lumen of the this tube. Other that suppose you are performing hysterectomy, and suppose any artery from the angle of the vagina is started spurting like that, then we use a clip and go and just press it, it will stop. Or suppose you are doing salpingo-oophorectomy and infundopelvic ligament you are cooking and cutting. Suppose you could not cook it and ovarian artery started spurting, you will go with the clip and apply. Many a time you have to apply. It is not only for the surgeon, any specialization you may need any time whenever you want. You know, most of the time gynecological practices are done in a destructive way that we do energy mode, because it is a reproductive organ, and once the work of a reproductive organ is finished, then generally we do not give any mercy to that. So, we use a lot of harmonic, ligacure, bipolar, cooking and cutting. But in most of the general surgical procedure, like suppose you are doing nephrectomy, you are doing splenectomy, at that time you cannot use the energy. Another problem is that energy can only be used up to 7 millimeter of the vessels. Like electrosurgery can work on the 3 millimeter vessel maximum, harmonic will work up to 5 millimeter of vessel, and ligacure will use up to 7 millimeter vessel theoretically. But practically you never know, even in uterine also many a time ligacure does not work, and in spite of using it, it bleeds. In those situations, that is why we have to learn knotting and suturing. If we learn how to tie the knot on the uterine artery, after that these problems will not happen. And if you want to learn the knotting, you have to learn the needle holder. So, these are needle holders. Needle holders are basically single action jaw instrument, and there is one attachment here for cleaning, because these instruments you cannot dismantle, because it is rock solid hard. It is very, if you will, every time you will open, the jaw will not be so much strong. So, this is for cleaning. You have to take a syringe, attach it and flush the water, it will be cleaned. And how to hold the needle holder? You should hold by index finger and thumb. This is the way of holding the needle holder. and these 3 finger is to close, index finger is to open. You should not press like that, otherwise you cannot use it. So, these 2 fingers should be used to hold, and these 3 to close, index to open. This is open, this is closed, this is open, this is closed, this is open, this is closed. Take care when you are pressing the index finger in this lever at this point, the other finger must release, and when you are pressing the other fingers, index finger should not be over this lever, it should be open, and then it is closed. It gives you 3 click, 1, 2, 3, these 3 clicks. So, when you are holding, suppose this is a needle, and if I have to hold the needle, I should go with the partially open jaw and keep the upper jaw above the needle and press by the upper jaw. Automatically it will be erect up, automatically. So, how to do that? Suppose even if it is upside down like that, even if it is wrongly placed, like right now it is already erect, I am bringing it upside down. This is now upside down, and you have to press it. I should go by the upper jaw and press it by the upper jaw, automatically it will get erect. It is right now little bit forward angulated. So, if you want to make it perpendicular to the needle holder, then I have to brush the back, and as soon as I will brush the back, it will become completely at right angle, and then I can take the bite. These tricks you have to learn during the suturing knotting and the proper use of the needle holder. Needle holders are of 2 types, one is straight, another is curve. This is curved needle holder. If you see the jaw very carefully, it is curved, and this is a straight. Curved needle holders are better, because when you will take a wrap, the tip can be visible, but only problem of curved needle holder is you need 2 curved needle holder, one for left hand, another for right hand. But if you have a straight, you can use in any hand, because sometime you may have to take the needle holder in left hand, because suppose you want to take a bite on the left side of Cooper ligament for doing the bird suspension, then you have to use the needle holder in left hand. So, a straight will be a straight. If you will use the right hand instrument in the left, then it is bad, because curve is going not in the center, away from you. And remember, in any single action jaw instrument, moving jaw should never be down. This is blunder, because you will not see, because your vision is from above telescope, and it will not show you. So, this is a rule that always in the single action jaw instrument, moving jaw should be up. Even in open surgery we do that, but in open surgery hardly we use the single action jaw instrument. In open surgery almost all the instruments are double action, but in laparoscopy, because we need rock solid hard, because if you will make a needle holder with a double action jaw, if you will take a bite, needle will rotate, because double action jaw instruments are loose, they are not very much a strong hold. So, that is why you have to use it carefully. So, these were regarding the needle holder. This is also important, that this is for cleaning, and sometime you may have to lock it. Do you know why? Because if it is not locked, sometime what happens, that gas may be leaking from here. So, ideally it should be locked, although the amount of the leak of the gas is very less, it is approximately 0.2 liter per minute. So, this is not a big problem, but then also we should keep it locked here always. Once it is not used, it is locked, and it should be only open at a time of cleaning. So, this is not for anything except cleaning, so that you attach the syringe and flush it, and all the blood or pus or the dirt will come out and it will be clean. Now, the next instrument which you can just pass it both the curve and the straight to all of you. Self aligning needle holder was used once upon a time by the Ethicon, which has a cup jaw in the lower jaw, and there you want, so that it will press, and once the upper jaw will press over the lower jaw, automatically it will get erect up. But it is no more practical. Do you know why? It is good to hold the needle, but the problem is when you have taken a bite and when you have to take the needle out to hold the tip, at that time it does not work. You got my point, what I want to say? Suppose you have taken a bite and now the needle is only little out, then at that time it will not work. Another problem is, I will show you the video also. Another problem is that this self-aligning needle holder is not good for tying a knot, because it does not hold the suture nicely. Yes. So, just to align the needle, that is why it was not very popular and they could not market it. Just I will show you self aligning piston grip needle holder, like here. No, this is another video. This is the tendinous arc of levator ani muscle. This is the birth suspension surgery, and if you see here, this is a self aligning needle holder. So, in this needle holder, what is there? This is the self aligning needle holder, and you will take a bite, and here it is taking a bite in the vagina, and it will be sutured with the Cooper ligament. And see the tip. Can you see there is a groove there in this needle holder? Yes. But to hold the tip, you need another needle holder. You got my point? And then you hold the other needle holder, and then pull it, and then drop the. It cannot lift the needle its own. What you have to do? You drop the needle into this. Can you see that? And then it will hold and it will make it erect. So, this is self aligning needle holder. Now, problem is if you take a bite like this. Here we are taking a bite this way. And now bite is taken very good, very nicely, but again this needle holder is useless to catch the tip. Can you see that? And to catch the tip you need another needle holder. So, it is not fully functional, and in those situations it is less used, and moreover it is not versatile also. So, that is why nowadays curved needle holder is more used. Self aligned has a problem of holding the suture, problem of lifting. This was piston grip self aligning, and another one is a groove with the self aligning, but that also has the same problem, that it cannot hold the tip of the needle unless until entire needle is sitting in the cup, otherwise it cannot hold only the tip, or if you will hold the suture to tie the knot and tighten it, it will start slipping. After few use it will start slipping. Self aligning also I will demonstrate you, I will show you. So, this was regarding the clip applicator. Now, this is the Fallop ring applicator. Fallop ring applicator is one of the method of sterilization. We know that there are three type of obstructive, there are two type of sterilization. One is destructive, another is occlusive. Occlusive method of sterilization, in Asia Fallop ring is more popular, in USA Hulka clip is more useful, and Europe Filsy clip they use more. So, this is Fallop ring applicator, and this is a ring cone. This is a ring cone. So, you will put the ring cone over the Fallop ring applicator, and then you will use the Fallop ring, and just put the Fallop ring over the ring cone. This is the Fallop ring. It is made up of silicon, and put it over that. And then take the ring pusher and you can push it like this. And it is applied. It is applied. Sorry, little bit less applied. After that, I have to use another. Cone कहाँ गया? Cone निकाल के दो. Once it is wet, then it slides better. Right now it is dry. बहुत tight है. You know, that is why what we do sometime, if it is too tight, we use sometime the cone. Same company should be there, otherwise it does not go. Now it is applied, and once it is applied, it is applied. Now what you have to do? Suppose you have the tube, then open the jaw, hang the tube, and then slowly you fire it. Here is one ring selection delivery collar. This ring selection delivery collar should be 1 or 2. If you have only one clip, it is 1. Other is, if you have 2 clip, you will keep on the 2 first, and then it is done. And here the Fallop ring is applied. This is the, it is applied here. So, it is just like how you are applying your piles with the gun with the hemorrhoid, or just like how you are putting a hair band in your hair. So, if you have to apply the hair band, first you are putting the hair band over your finger and then taking a loop of the hair and discharging the hair band on the loop of the hair. Same way it works, it is a very simple, and you will do it also practically, you will practice it also during the dissection.
What about the outcome after usage of that? If the patient want to recanalize?
Then you can cut it and you have to do the recanalization surgery.
Recanalization is needed?
Yes, needed, yes. There is no possibility that, yes, if it is failed, that means you are in trouble. If you did it and if it is failed, then in India, you know, there are few cases in which the doctor has to pay for the education of the baby for 18 years. This is your adopted baby if you will fail. So, it is required, and you are not responsible for the recanalization. You are responsible. No, patient will come knowing this. You do not have to tell the patient. Patient will come for a sterilization, otherwise you are not allowed to do it. You are not allowed to do it your own without consent of the patient. In India, actually sterilization is promoted. Why she is asking? Because many countries sterilization is very bad religiously or other way, but our government always promote the sterilization, and here if you will get a sterilization done, money is also given to the patient. So that, and yes, so that they should be encouraged to control the population. So, now another instrument which I am going to demonstrate to you is the bipolar forceps. This is a bipolar forceps. The previously what we have seen is bipolar Maryland, and this is bipolar forceps. It is not insulated from outside, it is insulated from inside. If you see, there is a insulation, this is a plastic coating here over the jaw. ये इसको छूने से पता चलेगा. If you will touch it, you can see this is plastic. This is plastic, and only the tip is naked. Only the tip is metal. This is plastic. So, from inside both the jaws are insulated, so, and from here also two electrodes are there. So, this is bipolar forceps, which you can use for appendicectomy or for TLH. It is not very good because it is plated. So, sometime it gets stick with the tissue, and especially for uterine artery, Robi dissector, this one is better than the bipolar forceps. But if you do not have, then it can work, but it is always better because it is just like the Maryland. So, pressure is more, and if the pressure is more, then the melted elastin and collagen can fuse better, and that is why hemostasis is better with the Robi dissector compared to the bipolar forceps. Now, the next instrument which we will see is this is called as tritom, or it is also called as PCOD needle. Why tritom it is called? It has three functions. It can inject the vasopressin, it can cut it also by the attaching current here, and you can use it for suction also. So, it is used for ovarian drilling sometime, or for sometime salpingotomy. If you want to cut the antimesenteric border of the tube, then you can do the salpingotomy, because it is very sharp. So, that is why amount of the current required is very less, and only 40-watt current is used. For 4 poles should be punctured, 4 millimeter it should be introduced into the ovary, and only 4 seconds you should press the paddle, only 4 seconds, so that it should not overcooked, it should not burn, it should not destroy the ovarian cortex. So, this is 40-watt, 4 poles, 4 seconds, 4 millimeter, and 4 month time takes for testosterone level to go down. So, this is also popularly called as PCOD needle. By default it is in, so that it is safe, it will touch the bowel also, no problem. Once you go, then press it, and once you press, the needle comes out, and then you will activate the paddle, attach the monopolar and drill it, or sometime to cut the antimesenteric border of the tube, you can cut it like that, because it is very sharp. So, it cut with the less current. Hook should not be used to do salpingotomy. If here from here, no, the tip here it is, there is one needle also into this, through which in this model, in this particular it is not there, but in starch there is one needle. So, it will help you to inject the vasopressin also, and same instrument you can use cut. But if suppose in this one it is not there, then you have to use either percutaneous spinal needle to inject it, or you can use the aspiration needle, to inject it. So, this is tritom or PCOD needle. Yes, you can use it for CVD exploration also if you want, or to do the pyeloplasty to cut, you can use it. But ideally for CVD directly we should use endo knife. Endo knife has advantage that it will not use the current, because stricture is one of the problem. To prevent it, you can use endo knife, but if you want you can use there also.
So during mammectomy you can use it for injecting aspiration?
For that aspiration needle is better, because aspiration sometime in myomectomy you may have to inject 200, 300, 500 ml vasopressin. So, aspiration needle you can attach a 20 cc syringe and you can inject as much as you can. This is just for few ml, because in ectopics for mesosalpinx hardly 5-10 ml is required, but in myoma you need huge amount, because purpose is transient ischemia plus hydrodissection. Both the purpose is there in myomectomy. Here your purpose is no hydrodissection, only ischemia, isn't it? But if you want, if you do not have, then you can use it. Now, the next instrument we will discuss is, this is hook. Hook is a very popular instrument for the surgeons for cholecystectomy, so that they separate the gallbladder from the liver. It is also used by gynecologists for different type of colpotomy, if you want to cut the posterior fornix or sometime anterior colpotomy also. Hook sometime they use for ovarian drilling also, but it is not a good instrument to ovarian drilling. Do you know why? Because the surface area burns more, because it is not going perpendicular. Once you press it, this shaft also will touch the ovary, and ovary will get scarred, which can increase the chances of adhesion. So, basically if you do not have, then you use, and use very carefully, that only tip should go, this surface area should not touch, isn't it? So, this is hook which is used by almost all the specialization in different situations. They
Can be used in unruptured or tubal ectopic
you can, but ideally you should avoid. Do you know why? Because if you are doing unruptured ectopic, that is means salpingotomy or salpingostomy, in those situations what happens is that you want to make the function of the tube back, you do not want to lose the function of the tube. So, you need less collateral damage, and sharper the instrument you have, with the less wattage of the current it will cut, and if you are using less wattage of the current, then collateral damage will be less. So, tritome. If you see tritome, it is so sharp that even with the minimum wattage it will split. Just like sharper your blade is, better you can cut the skin. If your blade is blunt, you have to apply more force, isn't it? So, sharper the instrument, with the less wattage it will split. Hook, if you do not have tritome, then you use it. It is not like that you cannot use it, but tritome is preferred, because collateral damage will be less with the tritome compared to hook. Now, the next instrument is, this is a bipolar hook. Bipolar hook is used for the adhesiolysis. Suppose you have a flimsy adhesions of the omentum and all, then you can use bipolar hook. If you see very carefully, there is one silicon plate in between, and either side there is a metal, isn't it? So, this is a bipolar hook which you can use in many situations. Now, the next instrument is, this is a spatula. A spatula is used wherever you want fulguration. इसमें इंटरनेट लगा हुआ है. So, spatula is a very useful instrument wherever you have the, थोड़ा सा कीबोर्ड देना तो, fulguration. So, I will show you later. Suppose you want to do the endometriotic fulguration in the posterior cul-de-sac, around the uterosacral ligament, you have the endometriosis. Then you will use a spatula, and the back of the spatula you can do the fulguration. Fulguration is a coagulation current from some distance. Fulguration means coagulation current with little distance, and it, because surface area is very big, so it gives you the very nice fulguration. So, during ovarian surgery I will demonstrate you. So, this is a spatula. It is used by surgeons if there is a oozing from the liver in cholecystectomy. Then you can make a thin film of coagulum which will keep the bleeder behind by fulguration. So, it is very versatile instrument. Sometime in partial nephrectomy, if you have cut the kidney and now it is oozing, you can use, or if you want to do the hepatectomy, either you should use CUSA for the cavitational energy, but if you do not have CUSA, you can use a spatula to fulgurate. So, these are the instruments. Now, the next instrument which I am going to demonstrate is this type of different type of uterine manipulators. So, you have the different type of like Rumi uterine manipulator, Clement Ferrand uterine manipulator, and other Indian uterine manipulators. So, this is the replica of our Rumi uterine manipulator. If you will see here, this is the tenaculum, this tenaculum. So, this portion will go to the cervix. This is also changeable. According to the size of the uterus, you can change this tip. If the uterus is too big, you can use the another tip. Or uterus is nulliparous, you can use the smaller one. And then the cervix will enter inside and then you will bite it. Once you will bite it, suppose this is the cervix and it is going inside, and then you will bite the cervix like that and it will hook it over. Now, it is hooked and then it will go inside, and then this is the colpotomizer, half circle colpotomizer. This is just to seal the vagina, so that gas should not leak, and this half circle colpotomizer you have to keep on rotating, and then over the ring of the colpotomizer it will cut, so that total laparoscopic hysterectomy can be performed. So, this is the Indian version of the Rumi uterine manipulator. Now, this is a full circle colpotomizer, where you have the full circle colpotomizer. This is one Indian uterine manipulator without colpotomizer. Like suppose you want to do only the ovarian cystectomy or LAVH, then you do not need colpotomizer, at that time you can use it. So, advantage of this one is anybody can use it, he should not be trained for this. Once you will enter into the cervix, then you close it and the cervix will rest over that, this will go into the uterine cavity and then lock it, and after that anybody can lift, and anteversion and contralateral traction can be given. So, detail about these uterine manipulators. Pardon? This one generally we say Indian uterine manipulator without colpotomizer, but what you said is some other name?
Hulka.
No, Hulka is not this one. This is I do not know the name of this one. We say only the Indian. Yes, it is maybe V shaped, but this is the simple uterine manipulator, where you close then it opens, when you open it closes. Now, the next instrument, yes, all of us we will see, just pass it to the everyone. Now, this is different type of retractors. This is called as fan retractor. So, this is closed, this is open, this is closed, this is open. This is fan retractor. Fan retractor is used, this is also called as lever retractor by surgeons. And suppose you have a lever, you will put it like that and then it will go and it can lift the lever, and this is lever retractor. And only problem is that contact angle should not be 90 degree, like that if it is there, if you have put this just over the lever, it will damage the lever. So, it should be 24 centimeter away from the application site. Suppose you have to apply on the lever, then put the trocar for this 24 centimeter away, so that contact angle will be better and then it can lift. Can you see that? It should be more surface area. If it is like that, it cannot lift. So, this is 24 centimeter away. Another problem is if it is too nearer and suppose some momentum is trapped like that, you are in trouble. But if it is far away, I can pull it back and then close it and bring it out. Otherwise, cannula will not allow to bring it back. Just like suppose this is in the cannula and I am too nearer, cannula is here only, and then it is open and I am pushing something, and suppose it is trapped here, now I am in big trouble, because without closing I cannot take it back, and if I will close this tissue, bowel or momentum will cut. But if the port is 24 centimeter away, and then if I want, I can just pull it back and then close and then bring it fully out. So, that is why it should not be too nearer. If it is too nearer, elevation angle will increase, and if it is too nearer, taking it out and in will be difficult, because it will stuck with the cannula. So, that is why fan detector is very carefully used. Gynecologists are using sometime in unmarried girls, sometime it comes for myomectomy and all, where we do not want to use uterine manipulator. Then you can use myoma screw, but even if you do not,
Many wings also, 7, 8 wings.
3 and 5 is there, 3 and 5, 5 वाला है अभी यहाँ पर. There are 2, 3 and 5 is there, and it is available in 5 and 10 mm both. So, this is 10 mm and 5 mm is also available. So, now to prevent the problem of this blade, this is called as Nathanson's uterine retractor. NET Nathanson, NETHASON, Nathanson's retractor. This is very popular retractor, which has the advantage that it can take the shape of the organ. So, you just open it like that, and then slowly you will push it into the cannula, like that it goes into the cannula. After that, suppose this is a lever, then you rotate it, and once you rotate, it will make a, automatically it will bend, and it will make a shape of like that, and after that it can lift the organ which you want. Or if you are doing hysterectomy, suppose sigmoid colon is distended or bowel is coming in your way, then you can retract. Advantage of this one is that it is very soft, so it is not going to harm. In the fan detector, the problem is if your assistant is not very careful, then it can pierce like that, and one of the blade can pierce into the liver, it can start bleeding, or bowel can be trapped, or omentum can make a complete web or knot around these blades. So, this will be little dangerous, but here it is not a problem. When you have to take it out, you just take it and make it loose completely, and it becomes straight, isn't it? And then slowly you can take it out. During taking it out, one important thing is force should not be applied. It should be very gentle, because there is a wire inside. Sometimes if you are abruptly you are pulling it, this wire can break inside, and then these are the beads, like the priests which they use the bead. These are the small metal beads, and all can be broken and it will drop inside the abdomen. Now, you are in big trouble, because you have to bring a C-arm and do the laparotomy, because these are steel and a small metal which has to be find it out. So, very carefully you should pull it out. Majority of the accident happens then at the time of pulling. So, sometime what happens, it is stuck with the jaw, like you are pushing it in and this is stuck like that. Then what you do, do not apply the force, bring everything together, and then outside with the other hand try to bring it out. So, if it is not coming, that means it is hooked somewhere, like see this jaw is hooking. So, in those situations bring it everything out and then outside remove it. So, little care is required to use both the retractor, but Nathanson's lever retractor. Nathanson's lever retractor. Nathanson was one Egyptian surgeon who has invented it, Nathanson. So, this is very useful for your country. This is 10 millimeter. This is also Nathanson's lever retractor, which can be used same way. This is also good. If the internet would have been there, so देखो कहीं आ जाएगा. And this is also, you can see, this is also same. And after going inside, again you have to rotate it, and once you rotate it, then automatically it will make it like this. It is done. Nathanson's lever retractor is of two types. One is handheld, another is stand held. In stand held, what is there, that they have epigastric port and you can put it, and then you can directly attach to the OT table, so that you do not need the assistant to hold it. So, that is also very popular, but only problem is if you are not careful and if the patient moves, then it can create a big trauma. But if it is in the hand of the assistant, assistant will take care. So, in India we do not have problem with the assistant, you will ask one, you have 3, so you can hold it, but in USA sometime they use a stand held this retractor. So, this is Nathanson's lever retractor, this is the fan retractor, and other instrument what we are going to see is that this is endo knife. Pardon? No, this is handheld. For table is another. table 1 is another. Now, this is the endo knife. This is also a beautiful instrument here. You can see this is a knife here, and this is endo knife. It is very useful. Sometime if you are doing myomectomy or other procedure, endo knife is useful. So, I will show you this is endo knife. Use it very carefully because it is very sharp. Sometime if you do not have Morse letter, mouse देखें, if you do not have Morse letter and if you want to use, at that time you can use endo knife mouse. Okay. So, this is also very useful. Now, this is called as suction. This is trumpet type of suction irrigation. This is trumpet 10 millimeter, and this is called as flap valve. So, if you are pushing it away, it is irrigation. If you pull it towards you, it is suction. So, this is 5 mm, this is 10 mm. So, suction irrigation, as you know, it is very important. It is not only important to irrigate and clean and suck the blood, it is also important for the other purposes like blunt dissection sometime, or sometime you are doing myomectomy. So, in one hand you will put the myoma screw dikha do, and other hand you will use suction irrigation to enucleate it, because we are very reluctant. This is myoma screw. We are very reluctant to use any of the jaw of instrument, otherwise jaw may break and it may go into the uterus. So, suppose this is the myoma, you will put it and just rotate it, and once you rotate it is grooved into the myoma, and this is another. So, with this you will do like that, will do like that, because myomectomy needs a lot of force to apply. So, in those situations, just like finger how you are enucleating, here these two instruments are used to do the myomectomy. You will not use the Maryland, otherwise jaw will break and it will enter into the uterus, and now you are doing laparotomy. So, this is myoma screw, it is holding its own and it is also very useful. So, the other instruments are, these are the knot pushers. They are beautiful knot pushers. The detail about the knot pusher I am going to discuss with the knotting and suturing, and knot pushers are of many types. This is called as Bhandarkar knot pusher. It has one tip or and this, and here is one another on the back. There is one eye on the tip and another eye on the back. So, this is called as Bhandarkar knot pusher. This is used for the Rudder's knot, Miller's knot. These are the two popular knots with this. Another is, this is called as Clark knot pusher. Clark knot pusher is used for extracorporeal square knot. This is Clark knot pusher. You know, knot pushers are very important for the different surgeries. Without knot pusher, you cannot learn the advanced surgery. So, we will learn from today. Actually, today afternoon I am going to discuss the knotting and suturing for the second batch, because from tomorrow second batch will become first batch. So, I will demonstrate you and then you will do one time, and then in the morning tomorrow the second batch will practice it, and for the first batch tomorrow I am going to demonstrate you. So, this is the Bhandarkar knot pusher and this is the Clark knot pusher, and this is called as slit knot pusher. Here is one small slit here, that is used for western knot or granny's knot or Preslet knot. These are the knots. So, I cannot discuss detail about these knots right now, but I may show you few videos where the different knot pushers are required. Like suppose, let me demonstrate you that how the knot is, how much the knot is useful in your practice. Like suppose, if you are doing myomectomy and if you have a big myoma like this, first I will show you endo knife, and here you can see this is the myoma taken out, and then you can use the endo knife. This is endo knife. Can you see that? Yes. This endo knife is cutting here. It is cutting the myoma, and this is the endo knife which will cut the myoma, because you are not using morcellated hair. We are not using morcellated hair. So, this is the endo knife which is cutting the myoma into two half. And after that you can take a sponge in the sponge holding forceps, and you can push into the posterior fornix, and then you can do colpotomy. This is colpotomy. In the posterior fornix, this is colpotomy. Here it is scissors are used, but actually hook is better, because scissor can touch anywhere and it can do the damage. This is the sponge here, and now by the side of the sponge, this is claw forceps. This is claw forceps. This is a 10 millimeter traumatic grasper. This is 10 millimeter traumatic grasper, and now you can hold this myoma and you can take it out. And after that you have to close. So, this you can hold it and you can take it out, and now you have to close it. For closure you need to know the extracorporeal knotting. So, here there will be, this is the entire myoma is taken out, and then you can close it by the square knot, and that for that you have to use the Clark knot pusher. These are some small myomas, very small, which is daughter myoma we say. Here nothing is required, just directly with the bipolar. This is Robbie dissector. This is Robbie dissector. Can you see the plastic joint here? This is a bipolar Maryland. And now it is taken out. Now you have to close the vagina. So, there is a gloves in the vagina. There is a sponge inside the gloves which will prevent the leaking of the gas. And now you take 1 or 2 bite and then take the needle out and use the Clark knot pusher and do the closure of the vaginal vault. So, this type of knotting is very important. So, now this is a bite taken and then you bring it out, and this is Clark knot pusher, and this is doing the square knot. So, these all knots, this is Clark knot pusher here, and you will push it and it will do the past pointing. This is called as past pointing, and then you cut it. Again you take another bite and again you close it, because going below the uterus and then applying intracorporeal suturing by the needle holder is not possible. Do you know why? Because uterus is dropping down. Can you see that? See the uterus, and it will not allow you to make a C and a reverse C. It will not allow you to take a knot. So, in those situations extracorporeal knot has a beautiful advantage that suture itself is taking the knot pusher where to go, because it is sliding with the suture itself. So, it can go anywhere, and now the vaginal vault is beautifully closed. So, this type of, again suppose you want to do cholecystectomy and you have to apply, then without the knot you will not be able to perform. So, knotting and suturing is one of the essential part for the any surgeon to learn. Like here, suppose this is lap chole, I am taking it out. Here this is the clip applied, and then this is titanium clip. Let us see how the titanium clip we are applying. This is titanium clip, and here this is one clip, and then you will apply second. The distance from the first and second should be 3 millimeter, and then 6. Cystic duct is already clipped here, because I have taken forward first, and this is second clip. Now, your question is how I will know that it is 3 or 5? Do you know, you have to bring any instrument nearby, and magnification of instrument and the structure will be same, and that will give you the idea that how much is the magnification. So, this is 3 millimeter, this is 6 millimeter, and then you will cut it. And here it is, and this is the scissors, and you will cut it, and that is cholecystectomy is done. Now, but sometime what happens, you have a very difficult gallbladder, and in those situations you want to do the knot, and knotting is important, because without knotting the good surgery cannot be performed in the difficult cases. Now, again I will show you the different type of procedure in TLH, and in the TLH suppose you want to do the suturing. In those situations, where it is without uterine manipulated, it is a myoma screw is used, and now you will see here this is suturing. You will see this is uterine pedicle, this is the hump of the uterine. Can you see that? Here, this is skeletonized completely. Can you see the uterine there? Here, actually this is uterine here. If you see very carefully, it is visible. Can you see now? This is uterine, this is uterine, this is uterine. Here beautifully it is skeletonized. Now, take a needle, hold the needle holder, and take a bite completely, and then you tie a knot. So, this type of knot is beautiful, because there is absolutely no chance of ureteric injury, and you do not need a very advanced energy source, and here entire bundle will be ligated nicely. Now, feed the suture, this is Vickrey number, feed the suture. Why to feed the suture? There should not be any shearing effect. so that you can pull it without shearing. So, this is suture is feeded 4 times. So, at least 20 centimeter of the suture is feeded, and then you can catch the suture and then pull it out, and this is now Vandarkar knot pusher, which you will tie the knot outside and it is pushing it. This is Vandarkar knot pusher, and it will entire bundle will be ligated, and it will be a beautiful dumbbell formation. And see, the uterine artery is fully ligated, just like open surgery, better than open. In open, that much dumbbell you cannot apply, and it is that much dumbbell formation, because tip of the knot pusher itself act as our finger, and now it is impossible. This side of the color of the uterus change. You see, this side of the uterus color become pale, because it is completely. So, without using any advanced energy sources, you can use it. Now, there will be ligation of the other side. So, detail about these we will learn at any way. So, I have just given you these videos, so that the importance of these instruments. These are looking just like a simple rod, but these are $1,000,000 instruments, because sacrocolpopexy, the fundoplication, for the rectopexy, for gastric plication, for all the advanced surgery, you have to learn the knotting and suturing, and these are the extracorporeal knots which we will learn, and after that you can do any surgery. Once you are good in knotting and suturing, you can perform any surgery, there is no limit of. So, here we will learn altogether 12 type of different site of knot, like continuous suturing, interrupted suturing, then the intracorporeal suturing, extracorporeal different type of suturing. Then we will use how to use this knot pusher. So, thank you very much.